Okay, and welcome to the Davies Use Case webinar being presented by the Center for Addiction and Mental Health on monitoring protocol for Clozapine-induced myocarditis. This is the Davies Award-winning use case for the Value of Health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. And it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar. We have the Damian Janukovic, who's the Vice President of Information. It is my pleasure to welcome our speakers for today's webinar. We have Damian Janukovic, who's the Vice President of Information Management, the Chief Information Officer, and Chief Privacy Officer. It is my pleasure to welcome our speakers for today's webinar. First, we'll have an overview from Damian Kovic, who is the Vice President of Information Management, the Chief Information Officer, and the Chief Privacy Officer at the Center for Addiction and Mental Health. Then we'll have Dr. Tanya Tajarian present on monitoring protocol for Clozapine-induced myocarditis. Damian and Dr. Tajarian, thank you for joining us today.
Hello, my name is Damian Kovic. I'm the Vice President of Information Management, Chief Information Officer, and Chief Privacy Officer at Center for Addiction and Mental Health in Toronto, Canada. It is my pleasure to introduce our Davies Award-winning case studies. A few words about CAMH. The origins of CAMH can be traced to the Provincial Lunatic Asylum, which has been formed in 1848. And since then, CAMH's history has reflected the evolving societal and scientific view of mental illness and mental health. In fact, CAMH has often led the transformation. The history of modern CAMH starts in 1999 with the merger of 4 founding organizations, some of them with a clear focus on clinical care, others with a focus on research. Our transformation continues. As you can see on the slides here, we've been building beautiful modern facilities in the heart of Toronto and delivering modern set of services to our patients. But who are we now? We're the largest mental health and addictions hospital in Canada. We're fully affiliated with the University of Toronto. We do lots of research all the way from basic science to epidemiology, and we do consider ourselves to be a world leader in brain science. We have 3 main sites in Toronto and about 30 locations in Ontario. And we deliver a large number of services, including emergency departments, inpatient treatment, day treatment, and partial hospitalization models. Just in terms of some numbers, just to give you a scale of our operation, we see about 35,000 unique patients every year. Some of these patients are quite sick. As you can see, we see a large number of schizophrenia spectrum and other psychiatric disorders, as well as substance-related and addictive disorders. In terms of staff, we have more than 3,000 staff, and we educate the next generation of mental health professionals. Our research has been growing exponentially in terms of both output and value of grants awarded. Our clinical programs have really 4 different areas: acute care, complex care and recovery, as well as child, youth, and emerging adult program. Of course, we also have a number of clinical services that support those major areas. Over the last 6 years or so, we've been on a real journey of transformation into a data-driven organization. That journey started off with a complete IT infrastructure refresh and optimization. At the same time, we have undertaken a lot of standardization work of our clinical processes, as well as administrative processes, including centralized intake, which has prepared us very well for a clinical information system transformation. About 4 years ago, we went live with a fully integrated clinical information system, which has replaced the previous very hybrid model. We had a lot of paper-based processes, as well as a number of semi-integrated systems. We decided to go with a big bang approach and essentially ripped all of them out on one day and have gone live with an integrated system in the same day. One of the things that we've done really well is that at the same time as we were preparing for our clinical information system launch, we've spent a lot of time building our enterprise reporting as well as business intelligence infrastructure. Hence, very, very quickly after going live, we were able to produce data and show to our clinicians the value of the information they were entering. We continued on that journey. We've created a performance improvement team whose goal is simply to take the insights from the data and drive them into the units and change the performance of the units. We've continued to standardize through and invested heavily into integrated care pathways. And most recently, we launched Krembo Center for Informatics, which we'll touch on a bit later. Here's a high-level schematic of CAMH as a data-driven organization. As you can see, central to our organization is our clinical information system. That data from that clinical information system really feeds our enterprise reporting platform, which we call CAMH, which integrates a lot of other data sources. And this is really the source of data where our performance improvement team looks at and generates insights which can then be driven onto the units and works with our clinicians to drive those insights onto the units. As you will see from our case studies, there's been really a lot of really positive, incredible work that has happened through that interaction. We take the data from our CAMH platform, de-identify it, and move it to our neuroinformatics platform. Here, we join it and integrate it with brain imaging data, as well as genetics data and other omics data to create this really multidimensional longitudinal records of our patients. And just recently, we launched Krembo Center for Informatics, which really has a critical mass of computational scientists that use sophisticated techniques such as machine learning and artificial intelligence to derive the next set of insights from this longitudinal patient, multidimensional patient record to learn new things about the brain and how we can use that information to advance care through personalized medicine. Those insights are then brought back into our clinical information system to drive next set of performance improvement in care. We were lucky to receive a number of awards on our journey. We're particularly proud of our HIMSS Stage 7 designation, which we have achieved last year. So why the Davies Award? HIMSS frameworks have really guided our decisions around technology since the beginning of our transformation journey. What really resonates with us is the focus on achieving patient outcomes through technology. Hence, the Davies Award is a natural extension of the work we've been proceeding with over the last 6 years. I hope you enjoy our case studies.
It's Dr. Tanya Tajirian. I'm the medical head for the hospitalist service at CAMH, and I will be reviewing today the monitoring protocol for Clozapine-induced myocarditis. On the agenda, I will be first reviewing the local problem. I will go through the problem identification and its importance, then the baseline workflow we had and the baseline data. Next, I will be reviewing the design and implementation, the objectives, the solution selection, the interventions, and the end user involvement. Following that, I will be discussing how health IT was used. I will review the revised workflow and the solution details, and finally, the value derived. So the effect of our interventions on data, post-implementation adherence data, post-implementation outcome data, and finally, the return on investment. I will overview clozapine. So roughly 25 to 30% of individuals with schizophrenia meet the criteria for treatment resistance, meaning they should have failed at least 2 trials of 2 different antipsychotics before they are considered to be treatment resistant. Clozapine is the only antipsychotic with proven efficacy. Unfortunately, though, clozapine has substantial side effects. The most common and well-known is the risk of agranulocytosis. Agranulocytosis is reduction in white blood cells that fight infections, even though it has lethal ramifications, but its incidence is quite rare, less than 1%. The more common side effects of clozapine are constipation. Roughly 60% of patients on clozapine develop severe constipation. And the other one, which is we're going to be reviewing through our case today, is myocarditis. Myocarditis is basically inflammation of the heart. And what we know about it, in the prevalence in the world, is less than 5%. CAMH, Center of Addiction and Mental Health, houses the largest clozapine clinic in North America. Currently, we have roughly 750 patients, and the goal is to double that volume over the next 5 periods. Problem identification. So in the summer of 2014, the group of us, the hospitalists at CAMH, we were seeing cases that some of our patients who were being started on clozapine, they were developing vague clinical symptoms such as flu-like symptoms, abdominal pain, or shortness of breath with fever. We were unclear what that diagnosis means, so we brought a cardiologist expert in clozapine, and he educated us and told us that actually what we're seeing is a medical condition called myocarditis, and unlike the hematological important and regular monitoring for agranulocytosis with prescription of clozapine, myocarditis did not have any. So why is this important? Clozapine-induced myocarditis is a potentially fatal yet likely underdiagnosed complication of clozapine therapy. Its incidence, again, and there is no regular routine monitoring for myocarditis, except few countries such as Australia and New Zealand. Incidence is estimated to be at 3%. It usually develops within the first 4 weeks of clozapine initiation and titration, and it's considered as a hypersensitivity reaction with a fatality rate of 10%. So our basic workflow prior to our interventions, if a patient at CAMH was diagnosed to be treatment resistant, a decision is made by the psychiatrist to prescribe clozapine. The clozapine orders are entered, and if the patient, again, we did not have active monitoring, but if the patient developed myocarditis symptoms, they will, the psychiatrist will stop the clozapine administration, alternative antipsychotic would be prescribed, and then the patient could be rechallenged with clozapine after 1 year of cessation of clozapine administration. If the patient did not develop any symptoms of myocarditis, the treatment of clozapine would continue. So how do we do myocarditis monitoring? There's 2 blood tests. One is troponin, which is a cardiac enzyme, and the other one is C-reactive protein. It's an inflammatory marker. So the Australian myocarditis protocol, and that is the only one available in the world, says a patient most likely has myocarditis if their troponin is 2 times upper normal limit and or their CRP is more than 100. You can be starting to worry about myocarditis if the CRP was elevated and the CRP is more than 50. So our baseline data, 1 year prior to our implementation of any interventions, As you can see from this graph, we only had one patient who received the myocarditis monitoring protocol. And again, myocarditis monitoring protocol means the patient receives two blood tests. One is troponin and the other one is CRP. We suspect in June of 2014, we had that one patient who received the myocarditis because that is exactly coincides with the time that the cardiologist expert came to CAMH and provided that educational presentation to the hospitalist team. Our objectives. First was to standardize myocarditis monitoring protocol for all clozapine naive patients. Naive patients mean they have never had clozapine prior to our treatment. Next was to increase compliance to myocarditis monitoring protocol, followed by discontinue clozapine for patients showing warning signs of myocarditis, and finally, streamline ordering process to save clinicians time and prevent errors. Solution selection. iCare is CAMH's clinical information system, which helped us achieve HIMSS Stage 7 in June of 2017. Order sets provided an opportunity to support policy with technology to facilitate standardized practice. Benefits of using iCare: CAMH staff and clinicians are already trained and familiar with the system due to our everyday use. Reporting of current state and future states is available through existing infrastructure. Communication and automated tasks exist within the hospital-wide CIS. Change management, built resources, and governance structures are already in place and can be leveraged. And finally, standardized documentation and practice can be facilitated through workflow and build. In this slide, I will be reviewing the interventions we implemented. First, it was at the policy level. We included myocarditis monitoring protocol into our clozapine policy in October 2014. Next, we developed our myocarditis monitoring protocol, and we integrated them into our iCare clozapine order sets. This was done in November 2014. Next, we reinforced education with the cardiology expert in April 2015. The expert came to CAMH and this time provided an educational presentation to all ordering psychiatrists at CAMH. And finally, we made it mandatory, the myocarditis monitoring protocol elements into our iCare order sets by locking them in June of 2015. As you can see, if you enter the word clozapine in our iCare EMR system, you will see at the bottom the clozapine pretreatment order set, and on the top you would see clozapine initiation order sets. One, it's called simple with no titration schedule, and the other one is with a titration schedule. Strategic governance. CAMH has a very well-defined governance process which incorporates end users for changes to the clinical information system. We will outline some of the parts utilized for the clozapine order sets. An initial change request submitted by a clinician to the Integrated Health Record Council, who determines at that stage what approvals are required. For the clozapine order sets, this request was forwarded to the Pharmacy and Therapeutics Committee. The recommendations of the Pharmacy and Therapeutics Committee were discussed with both the hospitalist and physician user group. More details will be provided in the next slide about these committees. After approval, the order set was sent to the Clinical Change Advisory Board to facilitate the IT build. In this slide, as you can see, we have different buckets of end user involvement at CAMH. Integrated Health Record Committee granted the initial approval of need after a clinical request for change was made that included end user membership. Hospitalist user group, again, it is chaired by the medical head of the hospitalist service, and it basically develops and requests the changes for all medical order sets. Physician user group is attended by the psychiatrist at CAMH, and its chair is the Chief Medical Information Officer, and usually it involves roughly 15 physicians from all different divisions of CAMH. And finally, it is our Pharmacy and Therapeutics Committee that is chaired by the Director of Pharmacy and the physician pharmacist, and the owners. Sorry, I'm just going to rewind to the Pharmacy and Therapeutics. Finally, the Pharmacy and Therapeutics Committee that is co-chaired by the director of the pharmacy. They are the owners and approvers of order sets, and it usually includes minimum of 6 physicians and 4 pharmacists. Our revised workflow. Patient presents with TRS, as I mentioned, it's treatment-resistant schizophrenia. A decision is made by the psychiatrist to initiate the prescription of clozapine. As a first step, the pre-clozapine initiation order set is completed, and that is the baseline blood work that has CRP and troponin. Next, the psychiatrist will order the clozapine order sets, either with titration or no titration schedule. And next, that means basically the patient will receive mandatory blood work for CRP and troponin for the following 4 weeks. If the results are normal, the patient continues on clozapine treatment. If the patient has abnormal results, and again, this is a flag, it is an active monitoring for patients who are initiated on clozapine. We review the results, and if the results are critical, we stop the treatment. Alternative antipsychotic at that point is prescribed, and the patient can be rechallenged with clozapine after 1 year of cessation of the medication. The red boxes here, as you can see, are where the health IT was used within the intervention. Mandatory monitoring protocol. The pre-initiation order set requires that the patient receives a baseline ECG and a CRP and troponin. And at that point, the hospitalist will do a full workup to identify if the patient had any pre-existing cardiac disease. As you can see, what's highlighted in the red, we have CRP, C-reactive protein, and troponin as a baseline. Following that, the post-initiation order sets, the patient also receives, again, weekly clinical assessments by the hospitalist that also receives CRP and troponin monitoring for 4 weeks, as you can see bolded in the red box. This is, reminder, on top of the regular required hematological monitoring for agranulocytosis. I would like you just to point at the blue order there, which is called bowel care order set. I will review this at the end of my presentation. Effect of our interventions on data. Our intervention at the policy level included myocarditis monitoring protocol into our policy in October 2014. The effect of that, we increased clinical awareness and regulations to educate staff about clozapine-induced myocarditis and the effective monitoring protocol. Our intervention at the order sets level, when we integrated myocarditis monitoring protocol into our eye care order sets in November 2014, the effect was integration of monitoring protocol, increased speed of ordering, and provided a visual reminder about the monitoring protocol for clinicians. And finally, mandatory fields being locked. We reinforced by our intervention education with a cardiology expert in April 2015 and made the protocol elements locked in our eye care order sets in June 2015. The effect of that, we increased clinical awareness and enforced regulations to standardize practice for clozapine-naive patients. Post-implementation adherence data. So our data here, again, reminder, 1 year prior to implementation, any of our interventions, we only had 1 patient at CAMH that received myocarditis monitoring protocol. As you can see, our different levels of intervention, we went up from 88% with the policy implementation to almost 100% with locking myocarditis monitoring elements in our order set. Post-implementation adherence data, a reminder, as I mentioned before, 1 year prior to implementing any of our interventions, we only had 1 patient who received the myocarditis monitoring protocol. After our implementation of our different steps of intervention, we went from 88% by policy implementation to 100% with locking the elements of myocarditis monitoring into our order set. Basically, then we had 307 patients out of total of 315 patients that received the myocarditis monitoring protocol, and only 8 people over the period of 3.5 years that did not receive the monitoring. And we suspect that could be for 2 reasons. One, some of the patients, again, they are quite ill patients that will not, a decision was made that they would be unable to receive regular blood work monitoring, or the psychiatrist discontinued the myocarditis monitoring protocol because they were not convinced regarding its importance. Post-implementation outcome data, 27 patients out of 310 since November of 2014 have been identified who had abnormal results of CRP and troponin tests. So basically, either CRP was more than 100 and or troponin was 2 times upper normal limits. These patients were discontinued from clozapine administration due to suspected myocarditis, which means approximately 10% of which would have been fatal. Sorry, I just need to repeat the last sentence. These patients were discontinued from clozapine therapy due to suspected myocarditis, approximately 10% of which would have been fatal. In this slide, number of clozapine patients with myocarditis risk stratified by age and sex. As you can see, 13.5% of males aged 21 to 32 had clozapine discontinued. Return on investment. An average cost of myocarditis treatment could not be found in the literature. In the absence of this, a study from the Canadian Patient Safety Institute was used to estimate the cost associated with an adverse event. This study found the cost to range from roughly 4,000 to 12,000 Canadian dollars. For the purposes of this calculation, the cost of Canadian 4,000 was used to estimate cost averted by taking clients at risk of myocarditis off clozapine. While the cited cost was estimated within acute settings, non-mental health hospitals, the effects of an adverse medication event would be a physical as opposed to mental. Therefore, the cost of an adverse medication event in a mental health setting would be similar to an adverse medication event in an acute setting. As you can see from the side, the cost averted is around $108,000. Finally, I will be reviewing our return on investment. 27 patients were removed from clozapine therapy due to suspected warning signs of myocarditis, which means we most likely saved 3 lives. We are able to finally measure the true incidence of clozapine-induced myocarditis at our hospital, which is roughly at 8.6%. Currently, 27 patients were removed from clozapine due to warning signs. Our clinicians are able to more easily screen for clozapine associated myocarditis. We were able then to develop guidelines for clozapine cessation and reintroduction. And finally, our hospital is locally leading the way for clozapine-induced myocarditis monitoring, and we suspect and expect that the uptake of this monitoring protocol will be on regional and national level after we publish our results next year. Finally, as I mentioned earlier, myocarditis is one of the more common side effects of clozapine treatment, but the other one is constipation. It is estimated that 60% of our patients on clozapine develop severe constipation. It is also suspected that 50% of sudden deaths in the community of patients on clozapine is due to complications of severe constipation and bowel complications such as ischemic gut. Our protocols have been so well received in eye care at CAMH that we have moved forward with our similar to our myocarditis monitoring. We have clozapine-induced constipation bowel monitoring in our order sets, which I showed earlier, which means every patient at CAMH who is initiated on clozapine is asked twice a day by their nursing team if they've had a bowel movement, and if they have not, the nurse will notify the hospitalist that they have had no bowel movement for 72 hours, and they have an automatic PRN laxative ordered in our order set. Finally, lessons learned. Policy change can be supported by health IT to support adoption and enforcement. Order sets are effective at driving adoption of mandatory protocols. And finally, data sharing with clinicians is an effective method for practice awareness. Thank you.
Okay, we would like to thank our speakers for joining us today on this Davies webinar, and remind our listeners where to go find this information and other important Davies use case webinar information and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you for joining us today.